Hello and welcome to Perspectives on PH. I'm Steve Highsmith. PAH.TV brings you up-to-date coverage of the latest news and information on pulmonary hypertension research and clinical practice. We recently had the opportunity to speak with Dr. Richard Channick from Massachusetts General Hospital. Dr. Channick is also an investigator on the Seraphin trial, recently published in the New England Journal of Medicine. We asked Dr. Channick to describe the study and discuss how the results may impact clinical trials in PAH. First, he described the background behind the design of the Seraphin study.
The Seraphin study was really a result of what was felt to be a need to raise the bar, if you will, on clinical trials in pulmonary arterial hypertension. Previous trials that have led to our current therapies for pulmonary hypertension have typically been shorter-term 12 or 16-week trials that looked at exercise capacity as a primary endpoint. And experts in the field have felt it important to really look at long-term results or benefit, specifically on morbidity and mortality. We feel this is a very important endpoint in evaluating a long-term treatment for pulmonary arterial hypertension. And I think that was really the impetus behind designing the Seraphin trial. This was a true event-driven trial. In other words, the trial continued until the anticipated number of events were reached. And the study was designed in this way to really allow long-term treatment experiences. So what we wanted to develop was really a composite, clinically important morbidity mortality trial.
Dr. Channick then discussed the primary endpoint of the Seraphin study.
The primary endpoint of the Seraphin trial was time to first morbidity and mortality event. The composite of that morbidity and mortality event consisted of either death, need for lung transplantation, atrial septostomy, the initiation of parenteral prostacyclines like intravenous or subcutaneous prostacycline, or a clinical worsening event. Now, the clinical worsening event was a very robust endpoint because the patient had to meet at least 3 different criteria to constitute a clinical worsening event. And that was a criteria of worsening exercise capacity, as evidenced by a decrease in the 6-minute walk distance of at least 15% that was confirmed, worsening functional class or development of overt right heart failure symptoms, and this is important, and, not or, but and the need for additional oral or inhaled medication. So the patient had to meet all 3 of those criteria to be classified as having an event.
We asked Dr. Channick what makes the primary endpoint unique.
I think what makes the primary endpoint in the Seraphin trial so unique are several things. Firstly, although previous studies have looked at time to clinical worsening, those studies were typically, as I said, short-term trials. In addition, and maybe very importantly, all events in the Seraphin trial were blinded and adjudicated. So in other words, an independent committee went through every reported event to determine was this actually a morbidity event. And that's very different than previous trials where the clinical worsening was really in the judgment of the investigator and was not confirmed nor adjudicated.
Next, we talked about what types of patients were enrolled in Seraphin.
So the Seraphin study included patients who had group 1 pulmonary arterial hypertension, specifically patients with idiopathic pulmonary arterial hypertension, connective tissue disease-associated pulmonary arterial hypertension, repaired congenital heart disease patients, and HIV patients were also allowed in the trial, as were patients who had pulmonary arterial hypertension associated with drugs or toxins. The enrollment included functional classes 2, 3, and 4. The vast majority of the patients were either functional class 2 or 3, and that was fairly equally distributed. In addition, and importantly, patients could be on background therapy with either a PDE5 inhibitor or a prostacyclin. The vast majority of the patients on background therapy were on PDE5 inhibitors. And over 60% of patients enrolled in the Seraphin trial were on background PAH therapy.
Dr. Channick reviewed the primary results of the Seraphin study.
So the study enrolled over 740 patients, making it a very large pulmonary arterial hypertension study. Importantly, the treatment duration averaged 115 weeks. So there was a long drug exposure. And when we get to safety of the compound, that's going to be very important. Overall, 287 patients had a primary event, so met the primary endpoint. And we certainly saw significant differences between the event rate in patients on placebo versus both the 3 milligram and 10 milligram macitentan dose. The hazard ratio for the 10 milligram macitentan dose versus placebo was 0.55, or a 45% risk reduction with 10 milligrams of macitentan. For the 3 milligram dose, the hazard ratio was 0.7, or 30% risk reduction for the primary event. So here we see the Kaplan-Meier curves for the two dose groups versus placebo. And you can certainly see a significant dose-dependent effect on morbidity mortality endpoint for macitentan. And this effect was certainly highly statistically significant at the 10 milligram dose and statistically significant at the 3 milligram dose. And in addition, visually, you can certainly see the duration of this study, where the treatment time going out to 3 years. So this certainly is a very unique feature of the results of this trial, this sort of exposure time to the treatment arms.
In addition, Dr. Channick described the results of the secondary endpoints.
One of the clinically relevant secondary endpoints that we evaluated in this study was hospitalization or death, specifically due to PAH. This was a secondary endpoint, but pre-specified analysis. Hospitalization for pulmonary arterial hypertension, which we feel is a very clinically important secondary endpoint, was also adjudicated. In other words, the committee looked at whether these hospitalizations were in fact due to pulmonary arterial hypertension. And importantly, what we see here is a very robust effect of macitentan 10 milligrams and to a lesser degree 3 milligrams on hospitalization due to pulmonary arterial hypertension. Additional secondary endpoints included the effects of macitentan on 6-minute walk distance measured at 6 months, as well as the change in functional class at 6 months. And what we found was this very significant effect of macitentan on 6-minute walk distance at 6 months. It should be noted that over 60% of these patients were in fact on background PAH therapy. And it's known from other studies that the magnitude of effect on 6-minute walk distance is somewhat less in patients on background therapy. In addition, we saw improvements in functional class at 6 months in patients in the treatment arm.
We asked Dr. Channick what were the effects of macitentan on more traditional endpoints.
I think the 6-minute walk distance and exercise capacity still has a role in assessing the response to therapy. I think one way to look at it is that the Seraphin trial clearly showed prevention of worsening. So patients stabilized and they did well, like I said, in a long-term trial. Things like 6-minute walk distance and functional class really are measurements of improvement. And are patients walking further? Are they functionally improved? And I think the results of the Seraphin trial, where these parameters were assessed also further out than most trials at 6 months, really confirms that not just does this agent prevent worsening, but it led to further improvement in patients' function and capacity. So I do think those measurements are still important, but clearly the long-term effects on morbidity and mortality are very important as well, and again, what was new about the Seraphin trial.
We discussed adverse events and what was the profile of macitentan.
When we look at the safety and tolerability of the drug, it really seemed to be quite good. Adverse events reported included some of the typical side effects that we see in drugs of this class, including nasopharyngeal symptoms, so nasal stuffiness, some respiratory symptoms. Importantly, we did not see any more peripheral edema reported in patients on the treatment arm versus placebo. And edema has been reported in some other drugs in this class more frequently than with this agent. Some of the laboratory abnormalities that deserve specific attention included anemia and liver function. And again, these are laboratory abnormalities that have been reported with other endothelin receptor antagonists. Liver function abnormalities were not seen any more frequently in patients treated with the drug than in patients on placebo. And the overall rate of liver abnormalities was very, very low in all groups. Anemia was the one laboratory finding that did appear to occur somewhat more commonly in patients on macitentan versus placebo.
Finally, Dr. Channick discussed the conclusions of the Seraphin study.
The primary conclusion of the Seraphin trial was that macitentan, compared to placebo, significantly reduced morbidity mortality events and was safe and well tolerated in a long-term trial. I think factors such as the size of a trial are very important and the length of exposure. And that's frankly been one of the challenges or gaps up until now, is that the studies which have led to approval of our current therapies really have been small studies, a couple hundred patient studies done, as I said, over a 3 to 4 months period. And how do we extrapolate that to using a therapy for years in patients with pulmonary arterial hypertension? It really has been, if you will, a leap of faith. Now we're getting data that really hopefully answers that question. How does a drug work in a larger study over a longer period of time?
That was Dr. Richard Channick from Mass General Hospital in Boston. Thank you to all of the experts who contributed to this edition of Perspectives on PH. We look forward to seeing you here at PAH.TV as we cover the latest news in pulmonary hypertension.